Hello everyone and welcome to this Facebook Live seminar. Thank you for joining us this evening. I hope everybody's sitting comfortable, cup of tea, glass of wine. My name's Alison Schofield and I'm a Tissue Viability Service Lead and Clinical Nurse Specialist. Today we're discussing self-care in the management of leg ulceration, which is such an important aspect. As part of today's session, we will also perform a live wound assessment on a realistic wound created by and with thanks to Georgina Holder, our brilliant makeup artist. You will see the amazing results. This seminar is kindly supported by Essity. So now we'll move on to the presentation entitled Promoting Self-Care in the Management of Leg Ulceration. So the learning objectives for this evening are to understand why a holistic assessment of the lower limb can help improve those clinical outcomes. Remember, it's the whole of the patient, not the hole in the patient. We will discuss what treatment options are available to empower patients to be more self-caring in the management of their leg ulceration, and to understand the benefits of preventing recurrence and how to best achieve that in clinical practice. So let's first of all look at the anatomy and physiology of the lower limb. So within the lower limb, there's a complex set of events that takes place to support the normal functioning circulation system. You can see on the diagram there, the system is made up of the red section, which is the arteries, the blue section, which is the veins. There are valves within those. There's the calf pump, which is making the venous system function and pump the blood back up through the body. And there's also running beside that the lymphatic system, which is essential for everything to work effectively. So keeping that balance is essential. Capillary exchange is the process that occurs when the oxygen and nutrients are transferred into the surrounding tissues to keep everything healthy. So if you look at the diagram, we can see the blood's pumping up through the veins into the lungs, receiving oxygen and nutrients, back through the heart and down through the arteries, and that's a normal circulation, healthy system. The lymphatic system is responsible for the removal of all the waste products within the tissues, and once that process has taken place, everything is working as it should be. So it's essential to keep that balance going. So again, on this diagram, you can see we have superficial veins and they lead into the deep veins via the perforator veins. So if we put extra pressure onto the superficial veins, then we will end up with venous problems. So when the balance is disrupted, this is what we see. So you've got some diagrams on screen, and we have a box showing you a valve which has got within a healthy vein. So what happens is, in a normal healthy venous function, the blood pumps up through the veins, the valves close, and then we don't get any backflow or venous return of blood. When the vein is damaged, the valve doesn't close, so we get venous return, a backflow of blood, and then we have extra pressure on the superficial veins, and we have venous hypertension. And then we start to see the signs and symptoms of that within the legs that we assess. So what that results in, and you can see from the pictures here, we have signs of brown staining. That's hemosiderin staining, and that's the byproducts of the blood that are spilling out into the tissues, causing that. We can see we have ulcers on the legs here, and these are pictures of venous ulcers. So you will have all seen patients who come into your settings, or you see them at home. They might have had a knock to the leg, an insect bite for instance, and then after 2 weeks there's no signs of healing, and that's a result of the venous circulation being compromised, and then that shows that we result in these venous leg ulceration. So holistic assessment, as we said, is essential to identify the patient's ability to heal within a timely manner. Also, it's an important aspect of discussions with the patient around achieving objectives for the patient and the healthcare professional. So tonight we're using the case booklet to perform a live holistic assessment on a patient, and this is our patient Sam. Welcome, Sam. CASE is an assessment tool designed to help guide us through and to complete an accurate assessment of the lower limb. So we're going to start the assessment to identify the cause of Sam's leg ulcer using CASE. So it's really important, remember, that full holistic assessment. So what that includes is I will need to glean from Sam her medical and surgical history, any medication that Sam might take which will compromise her wound healing, nutrition and hydration, because of course we know nutrition is one of the most important aspects within wound healing. What type of pain is Sam experiencing? Because pain within leg ulcers can tell us a lot about the etiology of the actual ulcer. Any psychosocial history. Vascular assessment, of course, including Doppler to determine the ankle brachial pressure index, the ABPI. So that compromises that full assessment, and we'll identify the cause through that. So, we know that Sam has from discussions, and I will be able to tell you her history. Sam has a history of varicose veins, which occurred during pregnancy. Is that right, Sam? And she also spends a long period of time standing at work in her job role. Sam describes her legs as being tired and achy. Now, whilst in the supermarket, she knocked a leg on the trolley, not an uncommon thing, but Sam's wound failed to heal. So after 2 weeks, after 3 weeks, 4 weeks, 5 weeks duration we're at now, and the wound has no viable signs of healing. Because of this, Sam had to take some time off work, so it resulted in her being quite low in mood, I think I can say that, and also then affected her appetite. So we've got all of the risk factors then adding to the compromised wound healing. So we're going to complete the vascular assessment. So how do we do that? So we want to ascertain what the ABPI is, and that's one method for assessing for arterial insufficiency. So other methods considered can be a toe brachial pressure index, TBPI, but that may possibly be performed by a specialist nurse in your area. If you can't obtain accurate readings from your ankle brachial pressure index using a normal Doppler, it might be that you have to refer on for TBPI to be completed. However, this should always be completed alongside a full vascular assessment, and that includes, remember, the recent and past medical history, that holistic assessment, any surgical history that may have taken place, broken bones, things like that in the past. Cardiovascular risk factors, is there any history of heart disease, acute heart failure? The medications that have been taken, things like steroids, can reduce wound healing in a timely fashion. The symptoms that we're experiencing within the wound and the pain symptoms that Sam has. And that clinical examination of the wound and the leg itself, that visual assessment. Also within the AB and TBPI, we're looking at the waveforms. In a Doppler assessment, we want to listen to those waveforms, and we want to see if they're normal or abnormal. So we have some examples of waveforms to show you. So the first one we'll listen to is the triphasic waveform. So can you hear within that waveform there are 3 beats to it, and that's a normal triphasic waveform. So now we'll move on to the second one, which is a compromised waveform, and it's biphasic. So listen to the 2 beats. Did you hear that? So the last one that we have is the monophasic waveform, and this is just like normally a one whooshing type of sound. So I hope you could hear the differences with those, and when you're out in practice using your Doppler assessment, get used to listening to that waveform. So we've done our Doppler, and we want to talk about the ABPI, TBPI readings that we find. So a reading of 1 is normal. 0.8 to 1, there may possibly be arterial element involvement, but we can still apply compression in these situations. 0.5 to 0.8, there may be arterial disease present. And so you may want to speak to your specialist teams whether compression is suitable or not at this stage. An ABPI of 0.5 or below, we're thinking about a blue light. This is arterial disease present and we want to refer on to vascular services. The toe brachial pressure index, TBPI, has different readings within that. So we have a 0.7 normal and then we have abnormal below 0.64. But again, it would probably be your specialist services who would be completing this. So now we know, and we've done an assessment, a pre-assessment with Sam, and I can tell you that her ABPI is 1.1. Good news, we're in the normal range. Sam also had the trisphasic pulse sounds, so again, that's good news. Now we know from before that Sam has a history of varicose veins, and we can see on her leg that she has hemosiderin staining. She describes achy, throbbing leg and within the wound. All these are signs of venous insufficiency, so we are diagnosing Sam as having a venous leg ulcer. Now remember that some patients will present with edema as well. Sam hasn't presented with this at the moment. People may also have that dry, hard buildup of skin, hyperkeratosis, and they may have ankle flare. So that's that the venous hypertension, putting pressure on the veins, the superficial veins around the ankle, and they are often signs that we do see. So we're going to perform a wound assessment on the ulcer that we can see that we've had applied to Sam's leg today. So I've always wanted to say this, here's one that we made earlier. So we're going to use a TIMES framework, a TIMES wound assessment framework to assess the wound. So alongside me, I want you to look at this wound and see what you can see. So T, that's the tissue status. What is it that you can see in that wound? So we know we've got some sloughy tissue, we've got some granulation tissue. Is there any infection there? We can't see signs of clinical infection. There's no spreading erythema, heat. Yes, we have some throbbing pain, but not pain to the extent where we would think it was an infection. We haven't got an excess of exudate also. There may be biofilm present, and we've got bacterial burden with the slough that we have there. Now we need to look at the moisture balance, so we know that it's not excessively wet, but when we start to clean up and we start to debride that slough, we're going to get some moisture there. So we need to think about the moisture balance because we want to protect the wound edge and also the surrounding skin. So in assessing Sam's wound, we need to look at the size. So we're looking at the length and we're looking at the width. Is there any depth to it? Now this wound is quite flat and it's uneven, and that's typical of a venous leg ulcer. There's no punched out with elevated edges to this wound. So working with the TIMES framework, the tissue we can see, we have slough there and we have granulation tissue. So we want to create the optimum wound bed. So that's we need to create an environment that is going to adapt and to de-slough that wound. We know we've got the bacterial burden, so also we need to think about our treatment plans of how we're going to tackle that. Moderate moisture, we've ascertained that which we have also. The surrounding skin we can see is dry and flaky, and Sam was saying it's quite itchy as well. And we know venous eczema can be a problem with venous leg ulceration and venous disease. So we need to think about the treatment plan. So remember, we're working with the patient at the centre of this and linking our multi-professional team, and that's the key to good treatment planning. The skincare is vital in the prevention of any further ulceration. Debridement to create that optimum healthy wound bed. Wound bed preparation to reduce bacteria and that biofilm. Biofilm is like a force field above that wound, and we need to penetrate in there to get rid of it, and so we're overall preventing infection. The exudate management protects the wound edge and also that surrounding skin. And then ultimately the compression therapy reduces the pressure in those superficial veins, and then we return the venous system back to a healthy one. So our treatment plans are going to be wound bed preparation. So what we're going to do with that, we're going to debride the wound. So we're going to provide therapeutic wound cleansing, and we can do that using, it's a chronic wound, so we can safely use tap water, we can use gauze, we can use a pH soap or an emollient substitute. We can use monofilament pads on the wound to disrupt biofilms and to help to cleanse out the slough. If there's any necrotic tissue, and if there was necrotic tissue, I would be a little bit concerned because it's non-viable tissue. So we need to, when we've done the ABPI, is it safe to debride the necrotic tissue? If it's below the ankle, then we need to be thinking about, is there some arterial involvement there? We want to reduce the risk of infection, so we will use aseptic techniques as appropriate where we can. And remember, for those of us who work out in community, when we're in our own home and there's the dog and the cat running around, then we might have to use more of a clean technique. We want to think about antimicrobials. We don't want to overuse them antimicrobials, but we want to use them when it's appropriate. So observe for the signs and symptoms of clinical infection, and using your local formulary and guidelines, use your antimicrobials or antibiotics if it's looking like we have systemic infection. So the patient will start to feel unwell and we can see that spreading erythema from the wound edges. And consider prophylactic treatment for patients at high risk or patients who have recurring cellulitis. So in exudate management, our treatment plan, we need to manage that exudate volume and viscosity to prevent damage to the peri-wound skin. So we can consider things like products like foams or superabsorbent dressings. It depends on the wound conditions really. So a foam is typically for low to moderate exudate volume. It absorbs the exudate, it allows evaporation to occur. They're easy to apply and they're low pain removal. We don't want anything that's stripping on that fragile surrounding skin for the patient. And they are successful in many wound types. Some can leak under pressure, so if this happens, we reassess and we may need to do more frequent dressing changes, or we may need to assess the absorbency that we're using. Absorbent pads, superabsorbers, absorb and retain high volumes of exudate, and they're very absorbent. They can be a longer wear time and less frequent dressing changes. But bear in mind, they can become heavy once they're at full volume. Skincare, absolutely essential to the care plan. So general skincare is essential in maintaining the integrity and preventing further ulceration. So that peri-wound skin should be treated with a bland type of emollient that you'll have on formulary. The ulcer margins can be treated with a barrier preparation, and that can prevent maceration of the surrounding skin. So remember, we're going to have that exudate coming out. We're going to have to mop it up, but also protect the surrounding skin. Uncomplicated venous dermatitis usually responds to emollients. Sam's got some dry itchy skin and this will probably be sufficient. However, topical steroids may be required if the problem persists. Any failure to respond to topical steroids would indicate the need to patch test to uncover any sensitivities there, and then appropriate treatment prescribed. So compression as part of our treatment plan, remember this is to reduce the blood pressure in our superficial venous system. The vein diagram that you can see, so we have the baggy varicose vein with the compromised valves, and we have blood flowing up but also dropping back down. We have venous hypertension. Now with the application of compression, then this is aiding the venous return. So it's aiding the blood to return back up to the lungs to get its oxygen, nutrients, and then pump back round through the arterial system. There are various types of compression we can use these days, and the best practice statement, first line, is to use hosiery kits where we can manage the wound with sufficient dressings. Also, we have now compression style wraps, which are great to apply, and a lot of patients do like them within self-care. We do have bandage systems, and we have some great 2-layer kits, so they're not too bulky, and if we need to reshape the patient's leg due to edema or manage high volumes of exudate with absorbent pads, then the bandage systems may be the treatment of choice. But hosiery kits generally now are the first line of choice. So with Sam, we're going to create a treatment plan. So Sam, one of the most important parts of the treatment plan is the skincare. So we're going to advise Sam that she can wash her legs daily. So that may be that she wants to get into the shower, she wants to wash her hair and everything else. We all do that on a daily basis to make ourselves feel better as well. So she can use cream, emollients as a soap substitute to the legs. We also want to think about the wound management. So we want to consider that debridement of that slough and that wound bed preparation. So a dressing that we're going to use today is Cutimed Sorbact, and the objective for that is the management of the bacterial load, because what the dressing does is the bacteria adheres to it, and when we remove it, it takes it away. We want to look at the exudate management. So we have a moderate amount of exudate, and we're going to choose a dressing called Cutimed Siltec foam dressing, which will be enough to manage the exudate from Sam's leg today. So now we're going to show you a short video demonstrating how to measure for a JOBST ulcer care kit, followed by an appropriate application. So we're going to now review a healed leg ulcer. What do we do with that, and how can the patient self-manage to prevent recurrence of a leg ulcer again? So chronic venous insufficiency is a long-term chronic condition, and the management for this is for life. So once the ulcer have healed, we need to create a new care plan. So patients that have suffered a leg ulcer will be at an increased risk of developing new ones in the future. It is essential that they are managed in compression garments and that they can continue to wear them for the rest of their lives. So we need to make sure we are choosing alongside the patient to get the appropriate and correct treatment. So how do we help our patients choose the right long-term garment? Garments vary depending on the individual's needs, and they come in different forms. We have circular knit, flat knit, and wrapped style compressions, and it can depend on whether your patient has edema or non-edema, in which knit will be appropriate to manage that. So how do we best decide with the patient which is the best option for them? Within compressions comes different classifications, and you can see on the chart on the screen 4 different types there. Now in the UK we tend to use British standard and the European standard, which is classed as RAL. And within that there are different classes. Classes 1 and 2 are typical ones that we use, and we don't be afraid to go higher if we need that. If that's important for the patient therapy, then we may need to look at a higher compression. It doesn't just always stop at 35-40. So which compression does my patient need, and realistically, how much can they tolerate? We always want to look at full therapeutic compression. We don't want to straight away go to reduced compression, but the patient has to be able to apply it and they have to tolerate it. So it's that partnership working. So factors that influence that choice are the ability to manage and tolerate the garments, the skin condition. So ideally, like we said with Sam's treatment plan, we want to be able to take the compression off every day, to wash the legs, apply the emollient, otherwise the skin gets very dry and it's more prone to breaking down. The shape, the size and the function of the limb are vital, so we want to manage that edema, and if anybody's got any contractions of the limbs, or they've got fixations at the ankle, people with rheumatoid arthritis, for example, can have these types of conditions. So we need to make sure that it's fitting correctly. Compression garments these days, we can add many different things into them. We can add zips, for example, to make them easy to apply. There can be silk little pieces inside at vulnerable areas. So it's not just one size fits all. Patients' dimensions, are they short? Are they too tall? So we don't want, for example, a compression garment on a tall person stopping halfway up the mid-calf. We want it to come up right to the knee. So we may need to do a made-to-measure in this circumstance. What's the patient's arterial status? Do we need to give them a reduced compression? Can we apply compression at all? Are there any other contradicting medical conditions that we can't apply compression, or we have to do reduced compression again? Things like acute heart failure. Neuropathy, for those of you who see patients with diabetes, is it that they've got neuropathic conditions, so they don't have much feeling in their feet, for example, or lower legs? They might have pain, like a nerve type pain. If they can't feel in their lower feet, then we need to be making sure we're telling them that they need to remove the stockings and to check for any signs of wounds or pressure damage underneath those. Patients' lifestyle, mobility, their manual dexterity, people with arthritis in their fingers, can be difficult to apply certain garments. Their age and their psychosocial status, what's happening within their life. And their choice, of course. And within garments, there is so much choice now. We can show patients that we have nice sheer garments. We have some with like a lacy top. Gentlemen, we have ones that replicate looking just like a sock in a various different types of colour. And we want to motivate the patient. That's why it's important for them to be on the journey, so they know all the facts, that they could have a recurring leg ulcer, and so they're more likely to stay with the regime and wear the garments. If there's a problem with life expectancy or a poor prognosis, obviously we want to be looking at the symptom management and the comfort of the patient, but it's not to say we can't use this for symptom management of painful, heavy legs, for example. And that partnership working, it's really important to work with the family, with the carers, with the patient, and also with other health professionals, so we get an accurate individualised treatment care plan. There are quite a few supportive aids out there which help patients to apply. I don't know the names of them all on there. One of my favourites is the marigolds on the end, but I do have it on authority that gardening gloves are a better fit and grip. And also things like a rubber mat. If you put your foot on there, it's not going to slip and slide. Your patients will come up with all sorts of ingenious ideas, so whatever works, but there are effective things on the market that we can use. So let's recap on what's happened with Sam and look at her prevention care plan. So we know with Sam that she had a trauma wound to the lower leg. 5 weeks, we've had no signs of healing. Sam has risk factors because she's had her varicose veins, which resulted from pregnancy. So because she has that compromised venous insufficiency, this makes her a higher risk of further breakdown of leg ulcers. And just because she's had the leg ulcer, the tissue there is very fragile. So we want to do everything to prevent her from getting a new one. So the options available with Sam are that, and Sam works, remember, so she wants to self-care for herself. So we've got simple dressings for Sam to apply, and we're also going to look at a hosiery kit that is easy for her to apply herself. And remember, there are other options out there, wraps, etc., which may be more suitable for your patient. Does that sound reasonable, Sam? Yeah, great. So now we're going to show you a short video showing you the application of compression for preventative purposes. So now also as part of Sam's care plan, we're going to educate on the importance of skin care. So Sam, we need you to remove this stocking daily, and we know that you can apply it very well yourself. We want you to get in the shower every day. We want you to use and then an emollient to keep that skin in good condition. We saw the dryness and the itchiness of the skin around it. The temptation to have a scratch as well and break the skin is high. So we don't want any of that going on. So it's important to look after our legs. Sam, it's important for you to look after your legs. The skin is the biggest organ in our body and we neglect it greatly. So everybody, please look after your skin. So in summary, chronic venous disease is a long-term condition that requires management for life. Education is key for patients around the importance of looking after their legs. Leg ulcer management plays an important part of any community nursing role, and that requires accurate and timely assessments. Preventing recurrence and encouraging self-care is imperative to a successful long-term outcome for this patient group. Now, I want to give a call to action to you. Excuse me. Now, I want to give a call to action. Following this seminar, I want you to look at and check your legs. Then, I want you to look at another person that you know and do the same. It might be your mum, your grandma, your dad, your colleague at work sat on the next desk, and post the comments of what you find on Twitter at JOBST UK using the hashtag #MyLegsMatter. Join the lower limb clinicians face group that we have, and that's aimed at healthcare professionals with an interest in lower limb. You can find that by searching on groups in Facebook, lower limb clinicians. I'm on there, and lots of other clinicians will be able to help you out. 1 second. TV. Legs Matter Week is the 3rd to 7th of June. Please visit their website to see how you can take part in raising awareness. It's so important to get these messages out there. So start looking after your legs, download your certificate tonight, and you'll be contacted by Essity for the chance to receive your very own pair of compression hosiery below knee garments, helping you to look after your legs. Also, Essity has academies which are free, online, 31 modules, including what you can see on the screen: anatomy and physiology of skin, factors affecting wound healing, infection management, surgical site infection, litigation, and the improvement assessment of wounds. So now we'll move on to our real-time question and answer session. So question 1, Susan Greaves, hello. Do you have to be a specialist to join the lower limb Facebook group? No, you don't. you just have to be a healthcare professional with an interest, or you work within anything to do with the lower limb. So you might be a generalist nurse, district nurse, practice nurse, you might be a podiatrist or a vascular nurse or tissue fibre nurses like us. Question 2. When would you use tap water and when would you use saline for cleansing wounds? So there's so much evidence out there that in chronic wounds like the one Sam has, is that tap water is absolutely safe and fine. Saline we tend to use for acute wounds, so we're talking 48 hours after surgery, for example. Pamela Buxton, good evening. Is biofilm always present? And if not, how can I tell it is? It's difficult to tell because it is quite a bit of an invisible force field. So if there's delayed healing, things are not responding well, then we can assume that the biofilm will be present. And then we need to look at treatments to try and disrupt that. And also remember, as part of cleansing, then using a monofilament pad, for example, can disrupt the biofilm, and then we can put dressings into place which will address that bacterial management. Sarah Hyde is asking, how many sets of stockings will a patient need per year? It's good practice, once a patient has healed, is to re-Doppler every 6 months. So, for example, we always say a pair to wash, a pair to wear. But if somebody like Sam is going out to work, for example, then she might wear out her stockings more. It depends on what happens in your local area. In my practice, in our chronic wound clinic, we give 3 pairs at one time because of that fact. Why should we consider using this type of compression? Well, if we're looking at hosiery kits for the management of leg ulcers or compression wraps, think about the patient. Now, patients like Sam going out to work, they want to put normal shoes on. Bulky bandage systems can compromise a person's mobility. So we want to look at what's best for the patient. Also, there has been studies, Venus 4 study, for example, you can look it up online, which looked at the wound healing between bandages and hosiery kits, and there was no difference in healing time of those. So the next question is, if my patient is non-compliant with hosiery, is it worth going down in class? It is. We always say start with therapeutic compression, which is full compression. We know it's difficult and some patients do struggle with it. It may be that they would prefer to have a wrap on, for instance, but any compression is better than no compression. Hannah Harris, good evening, is currently doing some work with the homeless community, fantastic, and saying, have we got any ideas and encouraging self-care with ulcer kits? How can we prevent recurrence with hosiery when access to washing facilities to wash stockings is an issue? That's a really tricky question. I'm not sure I can answer that entirely. There is a TVN, Jamel Geraghty, I know, who's in London, who's done so much work with the homeless, and maybe we can get some more information from her in experiences she's had to overcome this. Of course, the homeless community, sometimes it's a struggle to access services, and of course we do want them to go and self-care. So I'd like to come back to you on that one if that's okay. Kelly Robinson's asking us, are leg ulcers linked to diabetes? They can be. Diabetes is a risk factor, as are other comorbidities. That's why it's so important to look at that holistic assessment. Now, diabetic foot ulcers can occur, we know that, and that's not a leg ulcer, that's a diabetic foot ulcer. But yes, it can compromise the wound healing. How long should a Doppler be, how long should a patient rest before a Doppler, Kerry Church is asking. We always used to say 30 minutes, but actually we don't need that long now. I mean, ideally we want a patient in a supine, as flat as possible position. Not all patients can do that, so sometimes we do semi-recumbent. But a good, a good 10 minutes and we should have appropriate resting, and we should be able to perform that Doppler then. And our final question from Claire Pritchard, asking what about the ABPIs of above 1.3, and because they don't compress when they have this ABPI in their practice. Really good question, Claire. I've just been working on the best practice statement, which has just been published, and it's called Venous Leg Ulcers Complexities, and we do address this within there. So above 1.3, it might be that we just can't compress the foot pulsers with the cuff because we've got edema, for example. Patient history, have they got diabetes? Is it calcification in the arteries? If there's edema present, we need to then consider and speak to your specialist nurses. I personally, above 1.3, edema present, I will apply compression for that, because otherwise the ulcer and the symptoms are just going to get out of control. But seek advice in your local area. So this concludes our live training session. I'd really like to take this opportunity to thank Essity for their support in this event. Essity have a range of educational resources, and the contact details are on the screen. I hope this has helped you gain a better understanding of self-care in the management of leg ulceration. If you have enjoyed this event today, please like the JCM Facebook page and for details and access for up and coming events. Thank you so much for joining us this evening. Have a great evening.